So what we want you to be thinking about this morning is who is the right person for MIS? There's a lot of these great techniques out there. What can MIS do for you and what can it do? So our next speaker is Jay Turner, who will be speaking with us. It's Dr. Mummaneni, who's also going to be speaking with us about MIS techniques this morning.
Yeah, Jay and I look very similar, except I'm taller, so. We'll talk about considering MIS approaches in deformity. I do want to thank my fellow and my research analyst, Alicia and Tim Yee, for helping me put this together. I have the disclosures which are here. Okay, so this was mentioned earlier that we did do a deformity algorithm. We did 2 versions of it. We're actually working on a 3rd version of this now in order to incorporate things like osteoporosis and coronal malalignment. So in the original, we looked at it like this, and this was really based on a sagittal alignment. If they were really close to being balanced, you could just do an MIS decompression or a single level fusion. If they're moderately malaligned, then you end up doing typically laterals with perk screws. If they're pretty severely malaligned, some of those can still be done MIS. And we incorporate things like hyperlordotic A-lifts and mini-open PSOs to do that. That's the class 3. And then there are some you just got to do it open. If you have a double major curve, these little dots down in the bottom, double major curve, that would be considered like a class 3. And the class 3 is for people who have lots of experience. This was a secondary algorithm that we created. And the question often gets asked to me, when should I go lateral? When should I do a T-lift? When should I do an A-lift? So this article came out, and we tried to answer that question. And this is basically what we found after surveying some very experienced deformity surgeons, is that if you want to create lordosis, you typically can go lateral or you go A-lift. T-lift does not give you much lordosis when you do it MIS because you're not doing a PCO in the back. There's no facet osteotomy to squeeze on your T-lift, so the T-lift doesn't give you much lordosis. So if you want lordosis, do lateral or do A-lift is basically the bottom line of this algorithm, and I'll show you some cases to just show that. If you're able to follow those algorithms, you do have some papers that are showing some very nice clinical benefit. They came out of the MIS ISSG. Many of the folks here in the room were co-authors on that. We also looked at moderate deformities and what happens when you do those with MIS, and you do decrease the ICU stay, you decrease the hospital stay, and you do have less blood loss. So there's advantages to it if you can do these kinds of cases, and the complications when you don't lose so much blood and you don't put people in the ICU tend to be lower. What are the things to really watch out for? You got to consider the bone density. And now before we do any of these cases, everybody's getting a bone density test. Because that's going to create a problem. Even if you do inner bodies at every level, it creates a problem if they're osteoporotic because you'll have subsidence, and then you lose all your lordosis. And it is true when you do multiple laterals, if you spend a lot of time doing it, you can have after effects of temporary leg weakness, numbness, and I see that a lot, especially if we do multiple levels like L1 to S1 or L2 to S1. They almost always seem to have 6 weeks of trouble, and I think we don't talk about it, but we probably should. Let's run through a couple of cases real quick. This is somebody who is 80. This person's not going to really tolerate a whole bunch of big surgery very easily. Has severe back and leg pain. You can already see there's already been multiple laminectomies and now a flat back with an SVA of 10 and an LLPI of 17. And so, you need lordosis here. And you have up-down foramen stenosis because the patient's leaning forward, the disc heights have collapsed. Up-down foramen stenosis, you can do posterior decompression all day long, but you're not going to get that pedicle to pedicle lift without something in the inner body space. So this one will do nicely with lateral. You definitely need lordosis. And then we can do percutaneous on the back. So, you do the lateral. Here's the perk. I don't know if the video will play, but maybe it will. This is one of our residents putting in the perk screws with the patient on their side. There's no flipping, actually. We just do the lateral and go straight to the back side. We navigate everything. In order to get everything done in one stage. Fairly quick surgery. You can see there's not a lot of blood loss going on here. Now, if you do need foraminotomies, doing it in this position is not going to really work out for you. So if I have to do foraminotomies in the back MIS, then I will flip them prone. But otherwise, we will try to do a lot of these kinds of cases in single position, and that's the result. So you can see the SVA is much better. The LLPI is much better. We got 16 degrees of correction of the LLPI. And this person did not need to go to the ICU, was up walking around the next day. So you can really limit some of the morbidity. Here's another one, 66 years old. This one has this kind of a really kind of strange curve, concave to the left, and has these parameters with the coronal cob of 30. So yes, you could certainly do this open, but what about if you want to do it MIS? It looks like this. You have multiple levels where the disc space is asymmetrically collapsed, even 5-1 is collapsed on one side. And not too much stenosis, but there is some foraminal stenosis. But this foraminal stenosis is going to be treated very nicely, again, if you go lateral and if you use an ALIF. So this is, standard workhorse technique now for me. I'll do a lateral and an ALIF combo, depending on what levels I can reach, and then MIS perk on the back. And if I have to do a decompression on the back, I'll put them prone. And then, we can, lock it down, and then, essentially you end up with this. And that patient also does not need an ICU stay and does not need a blood transfusion. And you can see the coronal cob is down to 16, but more importantly, the coronal SVA is normal now. You can also do it for much more advanced cases of deformity. So this is a 78-year-old, already had an L4-5 Lammy at another hospital, lots of back pain, lots of right leg sciatica, and has a partial foot drop on the right. So this one's going to need decompression and is probably not going to tolerate a big operation. And if you look at this one, the LLPI here is quite high. It's 34 degrees of LLPI mismatch, and you also have a coronal offset, and you have a sagittal offset. So now you're talking about a more difficult case. This is a class 3 case. You really got to think about, am I going to overcorrect with my inner bodies, and what's going to happen? So this is the kind of case that I like to stage, and you can see this case is going to give me what I need it to give me because all the disc spaces are already quite arthritic, so I can put hyperlordotic cages at each level. Coronally, there's an offset already, L4 and L5. I've got to realign that, but I want to realign it in a way that I don't throw the patient off coronally any more than the patient's off coronally. So you can see a lot of up-down foramen stenosis, and that's all from disc space collapse. And some of this you can treat with indirect foraminal decompression, but this one is one that I'm nervous about indirect foraminal decompression not being enough because there's some central canal stenosis too, especially at L2-3. So on this one, I would definitely flip them prone and do some MIS decompression in the back. So we check their T-score. It's not terrible. Combination of laterals and ALIFs. And I stage this. And so first stage 1, lateral and ALIF combo. We get the patient up. We see how much correction do we get. What else do we need to do? Did their sciatica go away? How's the foot drop going? So I did this like on a Monday and a Wednesday, getting some imaging in between. Then you can see I did correct some of my stenosis, but 2-3 is still ridiculously tight. So it wasn't going to be enough for me to not go in the back here. And I'm glad that I staged it. But I did stage it, and this is where we ended up with an LLPI now that's 9 degrees and an SVA, which is really quite nice. Did stage it, but no ICU stay, no blood loss requiring a transfusion. So you can really use these techniques, even the more advanced techniques, to correct coronally, correct sagittally. On a case that probably maybe 5-10 years ago, I would definitely have done this open to try to line them back up. But by staging it, I can see how much more I have to do in the back before I go back there. So I think there are still cases where I can't do it MIS, where they have a hardware in from the prior surgery that I'm going to have to revise. They need a PSO for whatever reason because it got fused into a flat back with hardware. But there's a lot of cases which I can do MIS. And if the disc spaces are open in the front, I really use those laterals and ALIFs to my advantage to create the lordosis. And then, we can stage them, see how much more they need. Do their leg pain and their weakness go away? And then, get them back into alignment. So MIS techniques are becoming more and more powerful. They reduce EBL, they reduce complications if you pick the right patient, and those algorithms can help you. Thanks very much.